I'm Devora Aharon. I'm an attending physician at Reproductive Medicine Associates of New York and on faculty at Mount Sinai. And tonight I'm going to be talking all about egg freezing. So we'll talk about the process, what it looks like, what predicts likelihood of success, give some information about aging and how that affects the eggs and, helps to think about good time, to go through the egg freezing process. If you have any questions, please put them in the chat and I'll get to all the questions at the end. I'll leave a good amount of time for questions. All right. So, the idea behind egg freezing, as you're likely aware, is that it gives you an opportunity to harness your reproductive potential when you're younger, when your egg count is higher, your egg quality is higher, and to be able to use that in the future when it may be harder to get pregnant. It's a way to really take some control, gain some flexibility in terms of planning your family, planning your future. It gives you more options. It gets harder to get pregnant as women get older. And the main reason for that is the eggs. And there's two factors that are somewhat related, but really different, the number of eggs and the quality of the eggs. So women are born with all the eggs that we are ever going to have. And as we get older, the number declines. At the same time, the quality of the eggs that are there also declines. And the quality and the number are not necessarily related to one another. In terms of the egg number, the most eggs that you're ever going to have is actually when you're about 20 weeks gestation in utero. You have about 6 to 7 million eggs. By the time you're born, that has already declined to about 1 to 2 million. And then by the time you hit puberty, you're already down to about 400,000. So even without even having started to ovulate, the eggs are just constantly declining in number, even early in your life. Once you start ovulating over the course of your reproductive lifespan until you hit menopause, you ovulate about 400 eggs total. So you're actually, a lot of people think we're losing a lot of the eggs through ovulation. That's actually a very small minority of the eggs. It's the eggs that are within the ovary that are, constantly declining. Once you hit menopause, which on average is around age 50, 51, that basically means that there's essentially no eggs left. At the same time, the quality of the eggs that are there is also declining. And when we think about egg quality, the most significant thing that we're thinking about is the number of chromosomes in the egg. Chromosomes are like packages of genetic material. You need to have the right number of chromosomes or the right amount of genetic material in order to create a healthy pregnancy. Every cell in the human body typically has 46 chromosomes. Eggs and sperm each have 23, so half of that, and they combine to make 46. There's always a certain portion of eggs and sperm that we make that are chromosomally abnormal, but this affects eggs more so at a relatively young age. And when you're trying to get pregnant and you're ovulating, you're releasing one egg at a time. There's one egg that has an opportunity to result in a pregnancy. If that egg has an abnormal number of chromosomes, most of the time it will not result in pregnancy at all. If it does, that pregnancy will typically miscarry. That's the reason for most miscarriages. At least 60, 70% of miscarriages are due to chromosome abnormalities that just sort of randomly come from the egg. Or it could potentially result in a baby that has Down syndrome or another disorder that's due to an abnormal number of chromosomes, but it basically won't result in a healthy pregnancy. Now, there's no test we can really do on an individual level to test someone's egg quality, actually. But we have pretty good data on egg quality, and so we can kind of predict someone's egg quality just based on age. And so egg quality is very tightly related to age. So this figure that I have up here is data that comes from over 15,000 embryos that were tested as part of the IVF process. Eggs are each only one single cell. They're very delicate. We actually don't have a way currently to test the egg to know whether it's chromosomally normal without essentially destroying the egg. But when we fertilize eggs and we grow embryos in the lab, embryos are 1 to 200 cells. We can take a small biopsy from the edge of the embryo, send it for testing, and find out whether the embryo is chromosomally normal. When the embryo is abnormal, it can be coming from the sperm, but most of the time it's coming from the egg because female age has a big impact on this at a relatively young age. So from these embryo biopsies, we get a good sense of egg quality. So this figure is showing the percent of embryos which are aneuploid, which means chromosomally abnormal, according to female age, which is along the bottom. You can see in the 20s and early 30s, kind of hovers around 30% abnormal, which is pretty significant. You know, it's close to a quarter to a third abnormal, but the majority of the eggs are normal at those ages. These spikes down here are thought to be sampling error due to smaller numbers of patients doing IVF in their early 20s, so probably just not as accurate to reflect the general population. But as you get into the 30s, you can see, you know, there's a slight increase in abnormalities up till age 35. Once you pass 35, the abnormalities start to increase. Now, it's not like it's a sudden spike at 35, right? It's not like it's this huge change and cutoff at 35, but the abnormalities start to increase more rapidly. By the time you hit 38, 39, it's about 50% abnormal. And then once you're in your early 40s, it starts to really jump each year, 60, 70, 80% year over year. So it becomes much harder to get pregnant at those ages. Past age 44, 45, essentially all the eggs are abnormal, and it becomes very rare to get pregnant at those ages with one's own eggs at the time. And then, you know, once you're in the later 30s and 40s, even if you do get pregnant, there's a much higher risk of miscarriage due to chromosome abnormalities. So when we're thinking about pregnancy, the likelihood of success is really mostly related to the age of the egg. Now, one thing that's important to keep in mind is that the uterus actually doesn't really age very much in terms of its ability to carry a pregnancy. The uterus is a muscular organ with a very highly specialized endometrial lining that can actually receive an embryo at almost any age, even past 44, 45, even past menopause. If we give some hormonal supplementation to prepare the uterine lining, we can create a pregnancy at almost any age. The main factor is whether that embryo is chromosomally normal. So if we have chromosomally normal embryos from eggs that were frozen when you were younger or from an egg donor, it's the same kind of concept. We have a high chance of creating a pregnancy at almost any age. So that's the idea behind egg freezing. We take those eggs that have a normal number of chromosomes, and then later on in life, we have high chances of creating a pregnancy. If you are, let's say, 41 years old and you want to get pregnant with eggs that were frozen when you're 31 years old, your chances of pregnancy will actually be closer to that of a 31-year-old. So it's pretty cool. Now, how does it work? So at the beginning of each menstrual cycle, the ovaries recruit or bring up a certain number of eggs into these small follicles that are filled with fluid. Follicles are these little pockets of fluid in the ovaries. Each follicle has one egg. And these follicles that are recruited at the beginning of the cycle contain the eggs that have the potential to grow and ovulate over the course of a menstrual cycle. Typically, one follicle is designated as the dominant follicle. That follicle grows. As the follicle grows, the egg that's inside of it matures and ovulates. It's released into the pelvis. The tube picks up the egg, and the egg has the potential to make contact with sperm and result in a pregnancy. The other follicles that were recruited at the beginning of that cycle will actually degenerate. Those eggs are thrown away. The next menstrual cycle, a new cohort of follicles, a new group of eggs is brought to the surface of the ovary. So with egg freezing and in vitro fertilization, it's really essentially the same process. What we're trying to do is to get multiple eggs to grow and mature instead of just the one that your body would naturally grow and ovulate. So here's another image to kind of demonstrate that. So these are the little small antral follicles that contain immature eggs that have been recruited at the beginning of the cycle. In a natural menstrual cycle, one follicle grows. This is the growing follicle with the egg that's maturing. This egg is preparing to ovulate, so it's going to be released into the pelvis as a mature egg. These other follicles will degenerate. These eggs essentially die. The next month, a new cohort is recruited. In an egg freezing cycle, we are giving medication to stimulate the ovaries and stimulate multiple follicles to grow. So the ovary looks something like this with lots of follicles growing and hopefully lots of eggs maturing. So we're essentially rescuing eggs that would otherwise have been thrown away from that cycle. We're not reducing your egg count in any way. You have the same number of eggs going forward. It does not affect your future fertility. And that's also why we can do multiple rounds of egg freezing, because each month, each cycle, you have a new group of eggs that's available to us. So this is another image similar sort of diagram, but based on ultrasound images. So this is the ovary, let's say at the beginning of the menstrual cycle with the small antral follicles that you can see. In a natural cycle, there's one single dominant follicle that will ovulate and the other oocytes become atretic, meaning they degenerate and die. In a stimulated cycle, you have multifollicular growth. So lots of follicles that are growing. We're rescuing those eggs to be able to retrieve them and use them whether now or in the future. How do we do this? We use hormones that your body makes normally. So the pituitary gland, which is in your brain, makes these hormones called LH and FSH, or follicle stimulating hormone. That's the main one. It stimulates the follicles. These hormones are typically made to stimulate one follicle to grow. So they stimulate the ovaries to grow one follicle. And then that produces estrogen and progesterone. We are giving these medications in higher doses. So we give FSH and LH, it's mostly FSH, and we're giving it in higher doses to stimulate multiple follicles to grow from both ovaries instead of just the one that your body would naturally grow and ovulate. So it's hormones that your body's used to, that your body's familiar with, but in higher doses. What does the process look like? We typically start with a menstrual cycle. You call us when you get day 1 of full flow. You come in on day 2 or day 3. That's when everything is essentially baseline. All your hormone levels are low. The follicles are all small. We want to start when the follicles are small so that they can grow together. We can also use a birth control pill to help with scheduling so that we don't have to be subject to when your menstrual cycle comes. If you have trouble or things going on at work and you want to schedule it at a certain time, it's totally safe to do that. It has no negative impact. Sometimes the birth control pill can actually help synchronize the growth of the follicles, so it can have some benefit. If someone's not getting a period, they may be baseline for a longer amount of time, and we can do essentially a random start. So it's not based on the bleeding per se. It's about finding you when you're hormonally at baseline. So there's some different ways to approach it, but generally speaking, we're starting, at baseline, which is at the beginning of the menstrual cycle. So you start injection medications. It's a small needle that goes in the abdomen, 2 to 3 injections per day. Typically, you're on the injections for about 8 to 10 days in total. While you're on the meds, you come in every 2 to 3 days for monitoring, blood work and ultrasound during morning monitoring hours. So the idea is it's in the morning before you head to work. You can, work it around your schedule. And as you get towards the end of the cycle, you're usually coming in every day for the last few days. So that's until, let's say, around day 10 to 13 of your cycle, right? It's about 8 to 10 days of meds in total. Once the follicles look ready based on their size, based on your hormone levels, we give a trigger shot, which is an injection that causes final maturation of the eggs. So the eggs are preparing to ovulate. But before you ovulate internally on your own, we do the egg retrieval to collect the eggs. So that correlates with roughly day 12 to 14 of a cycle with the vaginal egg retrieval. And this encompasses the oocyte cryopreservation or egg freezing process. Once you do the egg retrieval, you're essentially done with that cycle. You wake up from anesthesia. It's light anesthesia. You're not intubated or anything like that. It takes about 10 to 15 minutes, but you're asleep. You don't feel the procedure. We use a vaginal ultrasound with a needle that goes along the ultrasound, and the eggs are extracted through the vagina, so there's no cuts or incisions or anything like that. When you wake up from the procedure, we let you know how many eggs in total we got. And again, then you're essentially done. You have some recovery time. Typically, after the retrieval, we will look at the eggs under the microscope. Any eggs that are mature can be frozen. Sometimes some of the eggs that we get, or oftentimes some of the eggs that we get, are immature. And only eggs that are mature will be frozen. So the embryologist will watch the eggs in the lab over the course of the day. If they mature, then they'll freeze them. So here typically we'll call you the following day and tell you how many in total were ultimately frozen. So typically not every follicle grows, not every follicle gives a mature egg, but we try to get as many as we can. Now, this is, essentially a segment of the IVF or in vitro fertilization process. So when we're doing IVF, we take those eggs, we fertilize them with sperm, we grow embryos in the lab, and then we can biopsy and freeze those embryos. And those embryos can then stay frozen for future use or for current use, depending on when you want to get pregnant. Or they can be transferred into the uterus on around day 5 to 7 of embryo growth. So again, this whole continuum is the IVF process. Now, when we thaw eggs, let's say you want to come back and use your eggs in the future, we essentially pick up from where we left off. We thaw the eggs, and now we're here, the day of the egg retrieval. We fertilize the eggs with sperm, make the embryos, and then we can implant an embryo into the uterus. We can also test and refreeze those embryos. And then another thing that we can do is once those embryos are frozen, we give medication to prepare the uterus for the embryo at a later point in time. So this is sort of what the vaginal egg retrieval looks like. It's an ultrasound that goes in the vagina with a needle that goes along the ultrasound. And again, you're asleep for this, you don't feel it. The ovary is actually right up against the vagina at this point. So it's going essentially straight into the ovary here. This is what it looks like on ultrasound. The needle is going into the follicle. We aspirate the fluid from the follicle, and with the fluid, hopefully comes the egg. So how many eggs can we expect to get from this process? This is based on ovarian reserve testing, which is done with antral follicle count and AMH, or anti-Müllerian hormone. Ovarian reserve testing is testing to see how many eggs you have left. Not an exact number, but kind of ballpark range if it's normal or on the high side or on the low side. Ovarian reserve testing helps to predict response to hormonal stimulation for egg freezing or IVF. So the antral follicle count is the number of those small antral follicles that we can see on ultrasound at the beginning of the cycle. The number of those small antral follicles correlates with your ovarian reserve, or your overall number of eggs that you have. So someone with a higher ovarian reserve will have more follicles that are recruited, brought to the surface of the ovary at any given time. In an egg freezing or IVF cycle, what we're working with are those antral follicles that we can see on ultrasound at the beginning of the cycle. Those follicles contain the eggs that have the receptors. They have the ability to respond to the stimulating medication that we're giving. We actually can't draw extra eggs out of the ovary. We're working with what the ovary has brought up for us in that cycle. So with a higher ovarian reserve and a higher follicle count, that's more eggs we can get in one cycle. So when someone comes in for a consultation, we always do a vaginal ultrasound to see how many antral follicles we can see. That gives us a sense of how many eggs we may be able to get. Now, it's not a perfect predictor. Typically, not every follicle will grow and give us a mature egg, but it gives some sense, right? So if you have 5 total follicles, you're in a different position. You may need to anticipate doing more total cycles to bank more eggs compared to someone who has 20 follicles at baseline and can expect to get more eggs from that one cycle. The other measure of ovarian reserve that we use is a hormone called anti-Müllerian hormone, or AMH. This hormone is useful because it can be tested at any time during the menstrual cycle. You don't need to come in at a specific time. So anytime you come in for a consultation, we can draw your blood and check this level. It helps to predict response to ovarian stimulation because it correlates with your overall ovarian reserve and with the follicle count. So with a higher AMH, we tend to see a higher follicle count. That's more eggs we can potentially get in one cycle. One sort of FYI is that it can be suppressed in patients who've been on a birth control pill or some other types of birth control for a long period of time. Now, it's not actually harming your ovarian reserve. It's not harming your fertility in any way to be on the birth control. What it does is it's suppressing your ovaries from ovulating regularly. So your ovaries not recruiting those follicles in the same way while you're on it. So the ovaries are kind of quiet. And when we look at the ovaries, we can see fewer follicles, and we can sometimes see a lower AMH level. Once you stop the birth control pill, your AMH level goes back to your normal baseline. Sometimes that can take a couple months. So sometimes when someone comes in with a low AMH level, they've been on a birth control pill for a long time, we'll sometimes take a break from the birth control pill for a month or two before starting the egg freezing cycle, because we can potentially get more eggs from the cycle if they've been off the pill for a bit. One thing that's really important to keep in mind is that the ovarian reserve testing, the AMH, and the follicle count do not predict your fertility. They don't predict your likelihood of getting pregnant, your ability to carry a pregnancy. They do not predict your egg quality. They just tell us about the number of eggs that you have, which tells us about how many eggs we may be able to get in one cycle of egg freezing or IVF. When you're trying naturally, you're ovulating one single egg at a time. And what really matters is the health and quality of that one egg. That's mostly related to your age. So a 30-year-old, let's say, who, the majority of their eggs should be normal, whether they have a high ovarian reserve or a low ovarian reserve, they're still ovulating one egg at a time. So their chances for pregnancy should actually be pretty similar. It doesn't matter if you have, a ton of extra eggs or a few extra eggs, you're still releasing one at a time. So where this comes into play, where the ovarian reserve testing comes into play, is when we're trying to predict response to treatment. So what about outcomes? What can I expect? What's my likelihood of success? So one thing that is really important to know and to remember is that there's no guarantees with this process. No matter how many eggs you get, no matter how young you are, there's never a guarantee. But we can predict your likelihood of success. And there's different parameters that can help tell us whether you're, very likely to have a baby from these eggs or not. So there's a lot of steps that the egg needs to go through to get to a healthy embryo, to get to a healthy baby. And a lot of this is just part of human biology. It's quite an inefficient process, actually. And that's why it doesn't work to get pregnant every month. The natural fertility rate is maybe like 20% per cycle. It often takes a few tries. And we really see this play out in the lab with egg freezing. And when we use the eggs, the number of embryos that we can ultimately get. So one factor is that not every egg survives the freezing and thawing process. Our thaw rates here are very good, about 90, often 100% of the eggs survive, but every so often there's a thaw where, fewer may survive. Of the eggs that survive the thaw, on average, about 80% fertilize normally when we combine them with sperm. Of those, about 50 to 60% grow out into a high quality embryo. And then the proportion of embryos that are euploid or chromosomally normal depends on your age at the time that the eggs were frozen. Once we have a normal embryo, the chance that that embryo works is about 50 to 60%. So if you put all those numbers together, and a lot of this is, related to age, so it's variable from person to person, but it takes probably about 10 to 15 eggs to have a high chance of having one baby from those eggs. But, like I said, there's no guarantees. Sometimes we start off with 10 eggs and we get one healthy embryo, sometimes 6 healthy embryos, sometimes 0. It's rare, but it can happen. So ultimately, the more eggs you have at a younger age, the better your chances for success in the future. This is data from a study that was done looking at actual patients who came back to use their eggs and what was their success rate. And I think the main takeaway from this that's the most useful is that in patients who were younger than 38 at the time that they froze their eggs, they found a 70% chance of live birth, 70% chance of having a baby with more than 20 eggs that they used. So, I generally recommend to try to freeze at least 10 to 15 eggs, really ideally over 20 to have very good chances of having at least one baby. And if you want to have high chances of having 2 or 3 kids from those eggs, to try to freeze maybe somewhere between 20 to 30. And then again, the number that you can get is going to depend on the ovarian reserve, how your ovaries respond to the stimulation, what the maturity is like, finances, how many cycles you can do, how physically taxing the process is. It really can vary from person to person. So these are all things to think about. When someone is older than 38, let's say, they probably need to have even more eggs frozen to have really good chances because each egg has a lower likelihood of being normal. And so, someone who is, let's say, over 40 is going to have a little bit lower likelihood of success when they use their frozen eggs. But if they have a high ovarian reserve, or they can do multiple cycles, that will give them better chances for success. There are some online calculators that have been created to kind of help put this into, give a little bit more of a framework, put some numbers to it. Nothing is hard and fast. None of these apply individually to every single person, but it can help kind of give a framework. Also, if you've done an egg freezing cycle and you got, 17 eggs, like what are my chances, based on that specific number. So this can be helpful for that. So if you look at this, you plug in the age and the number of mature eggs. So let's say you're 35 years old and you want to know, okay, what if I got 10 eggs? What would be my likelihood? It gives you a 69% chance of having one baby and a 30% chance of having 2 babies. So not bad, but it's not 100%. If you do a second cycle and you can get 20 eggs, it goes up to 90% chance of 2 kids and 90% chance of 1 kid and a 66% chance of 2 kids. So this is a little bit helpful in terms of thinking about, target and goals. Again, there's never a guarantee. But if you can get a good number of eggs frozen, it puts you in a good position. And I always, a lot of people ask if there's like a cutoff. It's never too late, right? Even if you're 41 or 42, you have a lower chance of success with the eggs, right, relative to someone who's 25. But your chances are only going to go down going forward. And if you're not ready to get pregnant right now, it still makes sense, or it may make sense, to freeze eggs to give yourself at least a potential for success, because you never know. So I'm going to conclude with that and open it up to questions. Again, please put any questions that you have in the chat. I see one question, so let me open this up. The question was whether the recording is going to be sent out. So I don't believe we send out the recording. It's more for internal purposes, but we can be in touch about resources that we have. Any other questions? So the question is, what age do you recommend to freeze eggs? There's no one age. If you think about that slope, between 30 to 34, let's say, the quality of the eggs declines a little bit, but not a huge amount. I think there's kind of a balancing act between, if you're very, very young and you don't really know your timeline for trying to get pregnant, you don't know how likely you are to need to use the eggs, right? So like if you were to freeze eggs at 25, but you start trying to get pregnant at 28 and you want to have 2 kids and you're at 28 and 30, you're most likely you're not going to need to use your frozen eggs. But if you know that you are going to be studying or working, building your career, traveling, whatever it is, and you know that you're not going to start trying till you're closer to 35, then there's a higher chance that you're going to end up needing frozen eggs, right? So then if you know that that's the case, the younger that you can freeze the eggs, the better your chances of success. If you need to use them. There's no expiration date on the eggs. As far as we have seen based on our data, it doesn't matter how long the eggs have been frozen for. So if you freeze them when you're younger, it just gives you better chances because the eggs are going to be younger. So I think, these are all factors to take into consideration. So, when you think you're going to start trying to get pregnant, how many kids you want to have, how old you're going to be when you have your last kid. If you don't think you want to have kids, but you want that option in case you change your mind in 10 years, that's a really good reason to freeze eggs. A lot of people do it for that reason. But generally speaking, you'll get the best outcome if you freeze eggs younger than 35. So probably around like 30 to 35 is a good age. Late 20s is also good. But again, if you're over 35 and you're not ready to get pregnant right now, now is the time. Like the sooner, the better. How many IVF cycles is average for a successful embryo transfer pregnancy? So if we're doing embryo testing, once we have a tested embryo, it's about 50 to 60% chance of live birth. So that's with one embryo transfer. With 2 embryo transfers, it's like over 75% chance of one baby. With 3 embryo transfers, over 90% chance of having a baby. So 2 to 3 embryos gives you a very high chance of having at least one kid. The number of IVF cycles that you need to get there depends on your age and your ovarian reserve. So if you're younger and you have a high egg count, you can often get 2 or 3 embryos from one cycle, maybe even more. So if you freeze your eggs, for example, when you're 29 and you get 25 eggs, you have a really high chance of getting maybe even more than 3 embryos from that cycle. So that's one cycle that can give you multiple tries for a pregnancy. And so that's where age comes into play. If you're over 40 and your egg count is lower and your egg quality is lower, it may take 2 or 3 IVF cycles, 2 or 3 egg retrieval cycles to get even one normal embryo or 2 normal embryos. And so it can take longer, so once you have that normal embryo, your chance of pregnancy from that embryo is pretty consistent, but it's, how long it's going to take, how many cycles it's going to take to find that normal embryo. So the next question is about fibroids. So fibroids are benign growths of the muscle of the uterus. They don't necessarily affect fertility unless they are affecting the cavity of the uterus or inside the cavity of the uterus. So we have a question about intramural fibroids, which are fibroids that are in the wall of the uterus, not necessarily affecting the uterine cavity. So if it's not affecting the cavity, it shouldn't really affect chances of pregnancy, though it's, sort of uncertain. We're not 100% sure that it has no effect. At the age of 45, trying to freeze eggs is, I would say, overall going to give a very low chance of success. If you think about that chart, from women who were 45, most women are not able to make any embryos. Of the ones that do, it's maybe 5 to 10% that are normal. Now, that's something to work with. So if you have a good ovarian reserve and you can get a good number of eggs and you have good embryo development, you may be able to get a normal embryo, but it's overall much lower chances of success. The next question is, how long can you store frozen eggs? There's no time limit. So studies that have been done comparing outcomes based on how long the eggs have been frozen have shown no difference, whether the eggs are frozen for a few months or years. I will say that, in terms of really long-term storage, like 10 to 15 years or so, we do have patients who've had eggs frozen for that amount of time, but we don't have large-scale data yet to say whether that may have some subtle impact. So I think that's still a little bit of a question mark, but as of right now, based on the information that we have, there's no time limit to how long your eggs can be stored, and the length of time that they've been frozen does not impact your likelihood of success. In terms of the daily injections, there's a question to elaborate on the injections. So it's a little bit individual, but generally it's 2 injections morning and evening, and then we add a third as you go through the cycle. In some cases, we start with 3 or 4 injections, like 2 in the morning, 2 in the evening. It's a very small needle. The needle goes in the abdomen. Depending on the medication that you're using, sometimes you have to mix the medication a little bit. Sometimes it comes pre-filled. You may have a few of each. I will say it feels very overwhelming, like whoever mixes medication in their home, even if you're in medicine, right? It's very overwhelming for everybody. Most people say once you do like the first couple of days of injections, you get the hang of it and it's not as bad as you thought, and the cycle goes by faster than you thought. Again, the whole thing from the start of meds till the egg retrieval is about a week and a half to 2 weeks total. It's about 8 to 10 days of the meds till the last injection, then the egg retrieval is a couple days after that. In terms of pricing and insurance, so insurance does not always cover egg freezing, or I would say it usually does not. So like typical insurance plans don't cover egg freezing, but even if they don't cover egg freezing per se, we usually will still submit to your insurance and see what they come back with. Sometimes they'll cover a part of it, sometimes they'll cover some of the medication. So there are sometimes, there is sometimes a possibility of getting some coverage. Some companies have like special plans where they provide coverage specifically for egg freezing, so definitely look into that. You can also advocate within your company. A lot of times companies will increase coverage if there's a demand for it. In terms of pricing, ballpark range, it can be about 10 to 15,000 per cycle, depending where you go and how much medication you use. The medication can be expensive and it can really vary. If you have, more specific questions, you can, come to our clinic and get more information about that. If you have an IUD, it can stay in throughout the egg freezing process. It does not have an impact. You do not need to remove it. And that's one thing that is, really nice about an IUD and also about egg freezing. You can be on contraception and go through the process without having to interrupt that contraception. One thing that can be just a little bit sort of logistically something to consider with an IUD is that typically we want to start the cycle when you are hormonally at baseline, meaning hormonally at the equivalent of being in a menstrual cycle. When you have the IUD, a lot of women are still ovulating, and so hormonally your body is still cycling. You're just not having a bleed because the lining of the uterus is thin. So sometimes we need to do a sort of frequent blood work to figure out where you're at in your cycle to figure out the right time to start. So it may take just like a few extra visits to prepare for the timing of when to start the cycle, but it has no negative impact on the cycle itself. How does endometriosis impact egg freezing? So endometriosis is a huge and somewhat complex topic. And the question is, it may or may not affect egg freezing, and it really depends. So endometriosis is super common. And it is associated with infertility, but not everyone who has endometriosis has infertility. There's a lot of women who have endometriosis who never even knew about it. If you do have endometriosis and you have pelvic pain from it, it doesn't mean you're going to have infertility. You can have endometriosis and not have any signs of it on ultrasound. So where it typically comes into play with egg freezing is if there's an endometriosis cyst in the ovary. The endometriosis cyst may decrease the ability of some of the follicles on that side to grow and mature. And it also may block access to some of the follicles on that side. So sometimes we get fewer eggs if there's a large endometriosis cyst in that ovary that's in the way, meaning like the follicles are on the other side of it and we can't get through the cyst. We don't want to go through the cyst during the egg retrieval. So that's the main way that it can have an impact is mostly if there's a cyst. If there's no endometriosis cyst, then endometriosis really shouldn't have an impact on the egg freezing process. It is possible sometimes endometriosis can be related to a lower ovarian reserve, or it can have some impacts on egg quality. Again, not in everyone who has endometriosis, but there are some links. So those are also some other ways that it could potentially impact the process, but they're a little bit more hard to, kind of pinpoint and really measure exactly. There's a question about staying on the pill during the cycle. So you don't stay on the pill during the cycle. You take the pill before the cycle starts to help with timing for the cycle. So let's say you get your period and it's not the right time to start the egg freezing cycle, but you don't want to wait a whole month. When you get that period, you take a birth control pill, you take it for, let's say, a week or two, schedule when you want to stop it to start the cycle. When you stop the pill, it's as if your baseline is if you're at the beginning of a new menstrual cycle. And then you stop the pill and then you go into the egg freezing cycle. So you don't take the pill through the cycle, you take it up until you start the cycle, and it can help with scheduling. If unused, can I donate frozen eggs? So in order to be an egg donor and to donate eggs, the eggs need to go through a pretty rigorous screening process, and meaning not the eggs, you need to go through a pretty rigorous screening process for infectious disease testing, physical exam, and there's a whole like FDA regulated process. So it's challenging to donate eggs after the fact. Sometimes if you want to donate them to a specific person, that may be doable. There are some, sort of logistic challenges. So it's something to look into. But I would say, generally speaking, if you're planning egg donation with the idea that you may want to donate it down the line, I wouldn't have the expectation that you definitely will be able to do it. But definitely, speak with the clinic where you're thinking about it and see what options may be. If you do some of that testing before you freeze the eggs, it may open up the options down the line, but that testing can be kind of expensive. So it may not be worthwhile, unless you really think you want to donate them. In order to be an egg donor and be compensated, typically you have to be, doing the cycle as a donor from the beginning. So side effects. So this is a great question. The main side effects are bloating and cramping as you go through the cycle. So as you get closer to the egg retrieval, the ovaries get very large, the follicles are growing, and you feel it. You feel very bloated, and it can be uncomfortable. After the egg retrieval, as the ovaries are healing, they're also still a bit swollen, and the bloating and cramping can be worse. There's also a little bit of bleeding internally, small amounts, some fluid that accumulates. Usually ibuprofen, Tylenol, heat packs, rest are enough to help. And I guess, so those are the main side effects. Otherwise, fatigue is really common. The medications make people feel really tired. Sometimes some moodiness. I would say a lot of people ask about moodiness and mood swings and things like that. It's not usually too severe, but everyone's a little bit different. Fatigue is actually more common. The injections are morning and evening. You come in for morning monitoring. Our monitoring hours are about 6:45 till about 10, 11 a.m. And so, you should be able to go to monitoring and then go to work after. So you can live normal life. You can work through the process. You need to take off from work the day of the egg retrieval because you'll have anesthesia. Otherwise, you don't need to take off from work. You don't need to use your vacation time to do this. You do need to be able to maybe go to work a little bit later on those monitoring days in case there's, a wait time to be seen. But the idea is that you can kind of fit it around your life. I would say generally you may not want to have like a major presentation or something like really stressful just because it's going to be like a lot going on at one time. Not because it's going to harm the eggs or harm your outcome, but it's just like a lot. Um, in terms of limitations, the main restriction is no high impact exercise and no intercourse while you're on the meds and until you get your period after the egg retrieval, which comes about a week to a week and a half after the retrieval. That's when the ovaries are mostly back to their normal size, mostly back to baseline. The reason for those restrictions are mainly that because the ovaries are very large, there's a risk that they can twist or torse on themselves, and that can be dangerous. And so to reduce that risk, we recommend no high impact activity and no intercourse. That's the main restriction. In terms of like diet, there's no real diet restrictions. We recommend to avoid toxic exposures that are like generally not healthy, like tobacco, smoking, chemicals. Alcohol, we recommend not to drink during the cycle. If you like, need to have a glass of wine one night, it's not really going to harm anything, but ideally to try to avoid it while you're on the meds. Um, there's a question about whether the anesthesiologist is included. That may depend on your insurance plan and on the clinic. So that would be more sort of specific. If you have specific questions about the cycle at our clinic, I'd recommend to call in. You can also email me to ask any more specific follow-up questions. What about prepping your body for this before you begin, like workout and diet? So the short answer is that anything that's healthy for your body is hopefully going to be healthy for your eggs and good for the process. That being said, there's no like must. You don't need to delay your cycle because you need to be like clean for a couple months. The most significant thing is age. The number of eggs, the quality of the eggs are going to be mostly related to age. So taking months to like be clean is not really going to be beneficial. Your eggs are still going to be essentially declining in that time. But while you're preparing for it, it doesn't hurt to live a healthier lifestyle, and hopefully that will have some benefit to your eggs and to your fertility. So in terms of diet, a Mediterranean style diet has been found to be beneficial for fertility. That means like high in lean proteins, fruits and vegetables, whole grain carbs, avoiding highly processed foods, avoiding a lot of added sugars. So those are some of the things to think about in terms of diet that, again, it's overall healthy and potentially good for fertility. Sleep is actually really important. There's more and more data coming out that sleep really is impactful for fertility. Now, I would say don't stress too much about sleep. It's hard to get a lot of sleep. People are busy, but as much as you can, to try to get good, consistent, good quality sleep. And then again, avoiding like, smoking, tobacco, marijuana, alcohol in moderation, coffee, like 1 to 2 cups a day, exercise, some consistent exercise regimen. There's no like one type or one thing that you should be doing, but, sort of generally healthy lifestyle. Um, and let's see. In terms of how close together you can do multiple egg retrievals, so you can do them back to back. And that means like when you get your period after the egg retrieval, you go right into the next one. So you do the egg retrieval, and a week and a half later, you get a period. You can start the next cycle. There's no downside to doing that. When we've studied it, looking at whether you do them back to back or a little bit more spread out, there's really no difference. So you should do it based on what works for your life. A lot of people want to like do a bunch in a row and then be done. Some people need a bit more of a break and want to do it a few months later. The main factor is going to be age, especially as you get into the later 30s and 40s. A couple months can make a difference. And so that's the main thing to think about. You wouldn't necessarily want to space it out 6 months apart once you're at those ages. We do sometimes see that in a second cycle, if it's within a couple months of the first cycle, it seems that there may be a little bit of a higher response. The ovaries are sort of primed from the medications. it's not for everybody. You know, not everybody gets that effect. Sometimes you get fewer eggs in the second cycle, but a lot of times we can get more eggs in the second cycle. We also learn something about how your ovaries respond to the medication from the first cycle, so we can kind of tweak the protocols to be able to get more eggs, hopefully, in a subsequent cycle. But there's definitely no downside to doing them back to back and kind of, just trying to get as many eggs as you can, within a certain time frame. Um, there's a question about an elevated hemoglobin A1C. So let's say an A1C is a measure of insulin resistance and glucose metabolism. So if you have an A1C in the pre-diabetic range, we know that it could potentially have some impacts on pregnancy and health of the baby. It increases your risk for gestational diabetes, which can affect, yourself during pregnancy and the baby. And it may have some increased risk for miscarriage potentially, or fetal abnormalities. Whether it affects egg quality and if it affects the egg retrieval process and egg freezing is questionable. So that's one where I would say, you want to try to get the A1C down if you can, whether it's through lifestyle or medication. Depending on your age, you don't necessarily want to delay the process too much. So for a borderline A1C in the pre-diabetic range, I wouldn't say that you can't do the egg freezing cycle. For sure, no, you definitely can do it. It's just kind of a balance of like, maybe you want to try to optimize it for like another month or so, if you're younger, let's say, and a few months are not going to hurt. There's a question about sperm donation. You can pick some attributes of the sperm donor, whether you can pick the hair or eye color. You can pick usually they tell you physical characteristics of the sperm donor, but you don't necessarily know how the baby is going to turn out. So when we do embryo testing, for example, we test to see whether the embryo has the correct number of chromosomes, the correct amount of genetic material, but we don't necessarily know like the eye color, hair color, things like that. You can know the sex because the sex is dependent on the chromosomes. I think I went through all the questions. I'll hang on for a few more minutes if anyone has any more. Thank you all for being here and for your great questions. I hope you learned something, and feel free to reach out with any questions if you want to, schedule a consultation or anything like that.